This week on the BackTable Podcast.
I remember when I was a fellow and getting into this field, it was always these debates at conferences of imaging or physiology. Should I IVUS or do FFR? And, fortunately, as a field, both the imagers and the physiologists have kind of merged now. And it's a contemporary PCI operator, essentially, where we realize these are synergistic tools. It's not a one or the other. And you use them together to truly understand the full assessment of a patient so that we could offer them the best result.
Welcome, everyone, for another episode of BackTable Cardiology. I'm your host, Dr. Sam Safo, interventional cardiologist and endovascular peripheral interventionist from Baylor Scott & White, the Heart Hospital Plano in Dallas, Texas. I'm very honored to have a guest today, a friend of mine and an amazing operator and researcher, Dr. Evan Shlofmitz, coming to us from New York. Dr. Shlofmitz is an interventional cardiologist and a director of intravascular imaging at San Francisco Hospital in Roslyn, New York. And he's actually the co-director of Optimize PCI, or what's called OPCI conference, a very unique conference. We're going to cover some of this information today. He got his fellowship at Georgetown University MedStar Washington Hospital Center. And he's one of the few people who really thought, why not getting an extra year of intravascular imaging and physiology? So he's really an expert in this topic. And he got that fellowship from CRF Foundation, Columbia University. We're honored to have you here, Evan, and looking forward to talk today about low contrast PCI, but maybe, touch base about imaging as well.
Yeah, well, thanks so much, Sam, for the invitation. It's great to be with you this morning. And I think it's such an important topic. And I think as we'll get into, so much of it is based on intravascular imaging and physiology. So they're tied very closely together.
Excellent. So let's start talking about when we look at data, when we look at outcome for different trials in coronary intervention, and not only coronary intervention, we see it also in structural, we see it in peripheral, that acute kidney injury or CKD or end-stage renal disease patients usually do worse. And some of the thoughts is maybe the contrast injury that we deliver to the patient is playing a role. Can you comment about this statement? Is that accurate?
Yeah, absolutely. And, what they found is not only do this contrast-induced nephropathy have a major impact on patients, but the actual incident is not equal to all patients. So patients who've had pre-existing renal disease do much worse if they develop contrast-induced nephropathy compared to patients with normal renal function and who develop CIN. It's much more likely that someone with normal renal function at baseline has a recovery. So this is something that is very real, and it's continuing to occur with more frequency as we're doing procedures on an older patient population, and patients with CKD, thanks to modern medicine, are living longer and longer with this. So they're aging to the point where they need to get an aortic valve replacement or they need to get a catheterization for evaluation of their coronary disease.
When you look at guidelines, when you look at data, even from the old days when we did train in internal medicine, when you have someone with a high risk for CIN, contrast-induced nephropathy, many trials were done to look at how can we prevent that. Different medication were tried, hydration protocols. Besides doing a low contrast PCI, can you talk to me what other medical therapy or prevention therapy that we can do for those patients?
Yeah, so this has been such an important topic, for the past several decades, actually. And there's been so many strategies that have been assessed in different modalities with hydration or sodium bicarbonate or different proprietary techniques. And, unfortunately, most of these have been unsuccessful. There's sometimes one study which will show some promising benefit, but then in repeated studies, it's not consistently having benefit. And it's been very disappointing that there hasn't been this magic bullet or solution with any one given pre-treatment strategy or therapy to completely avoid contrast-induced nephropathy. And as a result, basically two things we've seen that happen. First of all, most clinical trials that exist on PCI exclude patients with advanced kidney disease. So our overall systematic understanding of disease states and different techniques and technologies in this patient population doesn't actually get studied because almost every clinical trial, every randomized controlled trial in our field excludes patients with advanced kidney disease or with end-stage renal disease on dialysis, for instance. So as a result, what typically happens, because there hasn't been a magic bullet, is this concept of renalism, where physicians just avoid them having procedures with contrast. And it sounds good at the surface. Obviously, someone has advanced kidney disease, just avoid giving them contrast. And that's fine if we're doing some screening test. But the reality is patients we know who present to the hospital with an NSTEMI and with an indication for angiography end up having less angiography and revascularization than patients without advanced kidney disease. And as a result, some of the appropriate therapy that they should be offered, they're not getting because of this fear, basically, of contrast-induced nephropathy, and because a lot of these strategies have just been unsuccessful in the past. And that's really where this whole concept of this unmet need for these patients who have an appropriate indication for a contrast procedure, but there was this realization we need to come up with a strategy to do this with less contrast. And we need to utilize modern technologies, techniques, and allow us to be able to take care of our patients irrespective of what their kidney function is.
As you mentioned, some of the trials were done for some of the medication or the IV fluid, and even what type of IV fluid has been challenging because some come positive and you repeatedly become negative. But also we have our patients who, unfortunately, they're getting sicker, and we have patients with heart failure, so you can't just give them unlimited fluid because they end up being with heart failure, or a patient with valvular disease. What's your protocol? In your lab, do you routinely calculate based on the GFR and age and weight and everything else the amount of contrast that you feel comfortable giving to the patient? And is that routine? Is that a routine practice in your cath lab prior to doing an angiography?
Yeah, absolutely. So we've instituted two things at St. Francis that have kind of standardized our protocol. The first is what we found that with these patients, we did a very bad job of assessing their hydration status and their volume status up front. And we've abandoned the pre-hydration for all these patients because, as you mentioned, due to their impaired renal function, a lot of these patients are fluid overloaded at the time of the catheterization. So we typically don't pre-hydrate. And we start all of our procedures in advanced renal disease patients. They all begin with an LVEDP. So by crossing into the ventricle, getting an LVEDP and understanding their current volume status, that basically dictates their hydration strategy. And we'll often just hydrate on the table, starting on the table after we get the EDP to begin with, and then do post-procedural hydration based on that LVEDP. So that's always how our procedure starts. All these patients, whether it's for a diagnostic angiogram or if they come back for stage PCI, we'll always repeat the LVEDP to guide the hydration strategy. And then the second thing, as you mentioned, the contrast. How much contrast is safe? There's a big difference if someone's GFR is 59 or if it's 15. And the best data shows the likelihood of contrast-induced nephropathy is minimized if we can keep that contrast to GFR ratio less than 1. Now, there's so many ratios and calculations in cardiology we have to remember, so we like simple things. And unfortunately, this is a pretty simple one to remember. Whatever the GFR is, that's your budget of contrast for the procedure. And I've instituted this into my timeout when there's all this information we're discussing in the timeout, but in any patients with CKD, I'll say it out loud what the GFR is and that this is our budget of contrast. And I find it does a number of very important things. I think it sets the tone for the whole room. First of all, that this is a low contrast procedure, makes everyone aware of that. It also serves as an audible reminder of what our budget is and intended use for the procedure. And often, sometimes you'll get focused in on a coronary lesion, and your tech or scrub might mention, we're halfway kind of to our budget. Maybe we should stage this next part. And you have that reminder. And then the biggest thing for me is just that accountability. If I say in the beginning of the procedure at the timeout, our plan is to use 19 cc's of contrast or less, I find that this is something that throughout the whole procedure, we're trying to stay within our budget. It's the same reason why people set a budget. You have that goal and you can stay within it. Now, of course, there's peri-procedural complications and things change and you have to give more. Sometimes you have to give more to get the best outcome for the patient. But by setting that budget up front, oftentimes, in the majority of time, you can stay well within that budget. And that's really what's been shown most effectively, more than any pre-treatment strategy, just keeping that actual contrast under their GFR ratio. And basically, the best way to reduce contrast-induced nephropathy is give less contrast.
That's fascinating. I think this is very practical advice. I think many try to avoid doing it because all the calculation is pretty complex and requiring age and weight and all this stuff. And I think just focusing on the GFR and trying to avoid using more contrast than what the GFR is, I think that's a really nice practical method. There are some AI-based computers system that some has implemented recently where they collect all the patient data and then give you basically based on that the risk of CKD and mortality and others. Have you guys implemented any of those and are they beneficial?
So I've seen that. We don't have that in our system, but it only benefits. So I think it only is helpful. The more you have awareness, very often, particularly in elderly patients, you get an elderly patient who, that's why you hear, I've tried to implement mentioning that the renal function basically and the GFR at the time of timeout every time, because what's often mentioned in our timeout, I know, is always the creatinine. And you can have an 84-year-old with a creatinine of 0.9, but it's going to be impaired GFR. And I think it's important taking into account the entire clinical picture beyond just an absolute creatinine value. So yeah, anything that's going to call your attention and at least make an operator think, you know what, this is not the case. I'm going to take my normal views. I need to modify my strategy. And we'll get into this, I think, more, over the next several minutes of what a low contrast procedure is and how we achieve it. Obviously, if it was the same as every procedure would be low contrast. So it takes modifying your technique and your strategies, but the more alerts you have and discussion of that, the better. So I absolutely think it's beneficial having this set up. I've seen it at conferences. I've seen some samples of it, but we personally have yet to implement that into our system.
I think one of the challenging part of this is that if you ask physician, busy interventionists, especially with the same discharge becoming a routine thing, and NCDR only catch, CIN or in a report when the patient actually getting tested for it, is that many physicians will say, I never have CIN. And we know that's not true because more like than not, those are the patients are not being tested. And then the downside of NCDR being, depends on the data that's coming in. If the patient doesn't get a BMP or kidney function test in 48 hours, then definitely the patient on record did not have it.
Yeah, maybe even before, because that's such an important point. The reporting and quality metrics. The intent of quality metrics is good to improve quality and outcomes for our patients. But one of the big issues with this is these patients, this is a big part of why these patients don't get their appropriate procedures because of reporting. And not only is this the concern with advanced renal disease of contrast-induced nephropathy, but one of our metrics is new onset of dialysis in a patient after revascularization. So who's at highest risk for that? Patients with end-stage renal disease, advanced kidney disease. And then another metric is transfusion post-procedure. And these patients with advanced kidney disease have underlying anemia to begin with. So very often physicians will shy away from these procedures because you have two things right off the bat that are high risk for having an outcome that's reportable, that's a negative impact on a physician and an institution. And I know there's a number of places that shy away from doing these procedures in patients with an appropriate indication. And I've heard stories of patients where they initiate dialysis prior to revascularization for the sole reason being, so you always hear, so they don't take the hit on new dialysis post-revascularization. And, we should never be doing interventions and procedures, solely for, doctoring the numbers of quality metrics. So you bring up a really important issue. Obviously, the intent with these quality metrics is to improve quality of care, but we have to be careful that we don't alienate patients for the same reason why, like in New York State with the mortality reporting, cardiogenic shocks and exclusion, because they want to make sure physicians take care of the patients who have a high risk of mortality but need revascularization most when they come in, cardiac arrest and cardiogenic shock. So, I think that is something that that further exploration definitely needs to be focused on.
And ACDR has their scoring system where include, some of the factors of, is emergent cardiogenic shock, patient history of chronic acute kidney disease, and give you the number that'll tell you the mortality risk. But also there are a scoring system for AKI that people can utilize prior to the procedure, which allow you to help, modifying the procedure or just prepping the patient first. So one of the things a lot of operators can misunderstand is, well, this patient on dialysis, what would more contrast cause as a harm? I mean, the patient is already on dialysis. Can you comment briefly on, if you have a patient on dialysis, do you really care about the amount of contrast? And two, if you implement some of those scoring systems, how can you effectively truly treat this patient as multidisciplinary with the role of nephrologist in this situation? Are there any role for nephrologist pre-procedure?
The biggest thing with a dialysis patient, very often you'll find they still make urine. And that's a big difference, protective mechanism for them if they still have the ability to make urine. And these patients have very low GFRs, and they're very susceptible to further progression in their kidney disease. So if they're making urine, we treat that the same. We're trying to minimize our contrast volume. We always get the nephrologist in on board. And it's not that they're going to, our nephrologists, we work very closely in our cardiorenal program here at St. Francis. So they're aware, diagnostic angiogram we can often do in under 10 cc's of contrast. A stage PCI, we can sometimes, if necessary, we can do with zero contrast. We often prefer, and we could get into this a little bit more, but an ultra low contrast as opposed to just a zero contrast PCI in the majority of patients, but we can do with very low contrast. So it's not really that there's an issue with the clearance for it, is the patient cleared for the procedure. Typically, they are clearing the patient for the procedure as long as there's an appropriate indication, the renal function's stable. But I always get a nephrologist on board. I think it's very helpful just in the perioperative management. So often I find patients with CKD3 who've never seen a nephrologist. I'm the first person who's telling them they have kidney disease. And, we see this all the time that, I'm discussing their kidney function with them and, it really hasn't been addressed. And I think like with everything in medicine, we want prevention is easier than treatment. And we want to get patients established as soon as we've recognized the disease entity, get them to a specialist so they can be appropriately followed and worked up. So even if there's not much that the nephrologist is doing, sometimes if I'm cathing the patient that day, I still get a nephrologist on board to meet the patient. And this way they're plugged in with someone that they can follow with going forward.
Absolutely. I think you just pointed out the importance of multidisciplinary, and we've seen it in all the other aspects of medicine, from structural heart to other subspecialty, where multidisciplinary always end up with a better outcome. So the last 15 minutes, I hope the audience were able to convince them that contrast harmful, CKD is bad, and cerebral disease does not mean patient cannot be harmed by contrast. So you mentioned a few things. You mentioned low contrast PCI or intervention, ultra low contrast PCI, and zero contrast PCI. So let's start with, what's the difference between the three, and what are the technologies that you recommend having in the lab to allow you to do something like that?
Yeah, so what always begins with these conversations with these patients, we can send them a little differently, a little further discussion on the contrast-induced nephropathy in anyone with advanced kidney disease. But I also have a conversation with them that is setting expectations. And I tell them, we live in a community where convenience is certainly key, as many places in America. So patients like their PCI done at the time of diagnostic catheterization from a convenience standpoint, and I get that, and that's mostly our practice here. But for patients with renal disease, I always set expectations during the consent for the diagnostic cath. There is no intent to fix this today. If we find a problem that needs to be fixed with a stent and angioplasty, if there's something that's life-threatening, different story, we'll take care of it. But even if it's a straightforward lesion, we're going to stage our intervention. And the reason why is for that timeout that we have, where we talk about our budget of contrast. That's our budget of contrast. And you need at least 9 cc's for a diagnostic angiogram. And even if we could do the whole procedure with 0, we always want to have more budget of contrast available if there's an unexpected complication. And we know complications happen despite all the preparation and avoidance of complications. And if you lose a side branch, if there's concern for potential distal wire perforation, or you have no reflow, and there's all these scenarios where you might need to give some contrast, it's a big difference if you're doing it on a day where you've staged this and you've given 0 contrast to begin with and now have to give 3 or 4 cc's, compared with you're adding it on to all the contrast you gave for your diagnostic angiogram. So in stable situations, I believe it's safer to stage that. So I set that expectation 1. And right off the bat from your PCI, your budgeted contrast is different because you don't have all those diagnostic pictures. For the diagnostic, how do we achieve an ultra-low contrast diagnostic coronary angiogram? It starts with doing something different. So if you just do what you've always been doing, you're not going to save contrast. And the key is every bit of contrast has to answer a question. And you ask yourself, what am I trying to answer with this contrast? And if you can answer that question with another means without contrast, you go in that direction. So, for example, engagement, coronary engagement. Very often, you give a standard of care, you give a puff to confirm that you're engaged in a coronary. The ultra-low contrast protocol for that is we give saline instead. And by giving saline, you can't visualize that you're engaged, but what you'll see if you're bolusing saline down a coronary artery, there's going to be EKG changes that are noticed that confirm that you're well engaged. And someone will say, well, that's just 1 puff of contrast. I can do a puff with 1 cc, but what if you're not engaged? You're giving 2 puffs, 3 puffs on the left, and another 2 or 3 on the right. It adds up and every bit counts. And if you can answer that question without contrast, you're doing the patient a great service by saving that contrast. So it starts with engagement, where we use saline to confirm engagement in the coronaries, and then we change the views that we take. We don't take the standard views. We simply take 3 views. So in the left coronary system, we need 2 pictures. We take a AP caudal 30 and then an AP cranial 30, sometimes with a little RAO on it. And those 2 views are it for the left system. And we take 1 LAO cranial of the right system. And your question, what if it's an intermediate lesion? You're not really sure. Is it severe? Is it mild? Do we revascularize? Is it medical therapy? What do you normally do with an angiogram is you take another picture. But what we know, all that does is that contrast. And the reality is, in an intermediate lesion, 1 more picture usually leads to you still having an intermediate lesion where you need more information. And then your option is to take 1 more picture, and it's just adding unnecessary contrast without definitively answering the question. So if our first 2 pictures on the left system or 1 picture on the right doesn't definitively, if it's severe stenosis, we stage the procedure. If it's mild or no disease, we're done, it's medical therapy. But if you have an intermediate lesion, the next step, rather than taking a second picture, the next step is invasive assessment. And that's where the intravascular imaging and physiology come in. Because rather than giving more contrast, we can do a IFR pullback and an IVUS with 0 contrast. And now we have full assessment of this where there's no ambiguity of what the best management is. We know whether or not the lesion's ischemic. We know where it's ischemic, if it's focal or diffuse, or if it's multiple lesions. And we also have the information from the intravascular imaging to know, do we need lesion preparation? What size stent? What size balloons? Is this a complex procedure? When we stage this, are we going radial? Are we going femoral? Do I need a 6 French sheath or an 8 French sheath? Is it multiple wires and side branches involved that we need to protect? So you get the whole recipe for the procedure and strategy, just like we would do for a structural procedure. We don't walk into structural heart procedures, and once we get to the lab, say, oh, this is the valve that we want to deploy. All that's decided ahead of time, and that's how we have great outcomes in structural heart interventions. And ultra-low contrast PCI is taking that information, that multidisciplinary planning, and strategizing your procedure ahead of time, and you can be a lot more thoughtful and prescriptive this way. So that's basically a recipe for the diagnostic. For the intervention, it's utilizing...
So Dr. Shlofmitz, you just mentioned something very important about the diagnostic angiogram and ultracontrast. So I will kind of summarize for the audience is you don't feel the urge of using any contrast. So if to engagement, use saline, you will see some EKG changes. That's your way of telling that you are in the vessel. The two views that you recommend is an AP caudal, just be generous on the caudal, so 30 or so, and AP crani, also be generous on the crani, but maybe a little bit of an REO. And then don't feel the urge that you need to do 6 different pictures, like what we were taught, a long time ago. And for the RCA, the best view is LAO crani, where give you the whole RCA, the ostium, and the distal. And of course, if there is a need for evaluation of a lesion that's moderate, maybe another picture, not the right thing. So if I have a moderate lesion, and maybe we can talk us through what about this intervention? What's the best way to assess this moderate lesion?
Yep. So at the time of intervention, again, we always try to stage those. It's the same thing. We repeat with saline injections to confirm engagement. And then the rest of the procedure, depending on the GFR, that determines if we take a baseline shot. So we have our pictures on the boom from the diagnostic angiogram. If the GFR is typically single digit, we try to do a 0 contrast PCI plus or minus 1 final picture at the end. If the GFR, let's say, is 20, we know it's okay to do 1 baseline angiogram because there's a wealth of information that you get from a single baseline angiogram. When you're going to do the baseline angiogram, the key is the setup shot. The goal is to take just 1 picture for baseline. So you want to make sure you're in your working view. And that really just depends on what you're treating. And we do these procedures specifically in a Philips room. So we can use a technology called Dynamic Coronary Roadmap, or DCR. And that enables us, when we take a single cine, as long as you stay on for 3 beats, it acquires this dynamic coronary roadmap where you can see the vessels for the rest of the procedure without injecting any further contrast. And this is a game changer in the ability to wire the vessels, advanced devices. So you have all your anatomical landmarks because every time you're advancing a balloon or a stent or an imaging catheter, you see where the side branches are and different anatomical landmarks from the roadmap. So that's been a really effective procedure technology to help us minimize contrast. And then once everything's wired, we typically wire more vessels than we do on a regular procedure. Because by putting wires in all the relevant side branches, you create this coronary silhouette, and that also helps you to localize where devices are and where you're placing it, because those serve as landmarks if you're avoiding giving contrast. And then the only other thing that we do a little bit special, we try to make an exaggerated curve at the distal tip of the wire, because the one thing that you can't see with imaging and physiology is the distal wire perforation. So you want to be particularly careful that you don't create any distal wire perforation. And then other than that, the rest of the procedure is just an imaging and physiology guided procedure. And you realize that all the questions you're trying to answer with contrast can be answered with physiology and imaging. So if you do systematic imaging and physiology, you realize you don't need contrast. And what's so critical about that, once you realize that, you realize you can do this for every single procedure. And even if they have preserved kidney function, you can use less contrast if you use imaging and physiology. And the key is those are the patients to start this in. The first time you do an ultra-low contrast PCI should not be in a patient whose GFR is 9, because just like a CTO or any complex intervention, the best way to get good at it is by practicing and by experience. So the time to practice this is when you have a patient with normal kidney function, because you can check what you're doing. You can confirm it with a contrast angiogram. And by challenging yourself to do a low contrast procedure or a low contrast diagnostic angiogram in a patient with preserved renal function, over time you can get very efficient and good and know exactly the tips and tricks so that you can integrate this into your practice. So when that patient comes in with an NSTEMI with advanced kidney disease, you're prepared to offer them a high quality procedure with still minimizing contrast. And the funny thing about this, because operators are using imaging and physiology really to guide their procedure instead of the angiogram believe they're actually getting a much better procedure because it's all based on the intracoronary imaging and physiology as opposed to the angiogram, which we know is inferior to intracoronary imaging guidance.
You mentioned the DCR, and I think this is just to emphasize that it's not available on all machines. It says Philips, a very specific technology that used to be thought that will never happen because we have roadmap in almost every machine for the peripheral, but because the heart and it's a beating organ, it was thought that DCR in the road mapping in the coronary is not possible, and we're happy that Philips has put all their smart R&D engineers into action and got us this. So we use it in our lab, and I think it really game changer, and we teach all of our fellows. I think that's something to emphasize on it. When the other things you mentioned, and I want to emphasize on that, when we say physiology, most of the operators, when they say physiology, they put an FFR wire, they put an IFR wire, it's a 0.85 IFR, it's 0.75 FFR. Let me fix that proximal LAD lesion. But that's not what you're talking about. You're talking about a co-registration, pullback, assessing the length of the lesion that needs to be treated, not just if I am positive or not. Can you comment about co-registration? How do you do it? What's the right way of doing it?
Yeah, so with dynamic coronary roadmap, no question, Philips led the way with that, and it's a vital part of our practice. Some of the competitors are working on developments of similar type of technology, so more will be available, but Philips is definitely leading the way. And the rest of their portfolio is also why we do these procedures in a Philips lab. So they offer co-registration, particularly something called tri-registration, where they can integrate the physiology and the intracoronary imaging with the angiogram. So we put this all together to really guide our procedure. So physiology, your group as well has done so much of the work on using modern physiology. And we've walked away from this just using physiology value based on a cutoff, because cutoff values are for appropriate use criteria and for clinical trials. But that's not physiologic for a patient. There's a continuum of ischemia. And does it really matter if someone's FFR is 0.74 or 0.75 or 0.80 or 0.81? And yeah, that might be above or below a cutoff, but from a patient's coronary standpoint, there's very little difference. So what we've worked towards is using physiology as a continuum and really trying to understand the disease pattern. And over the past several years, there's been this evolution to really focusing on whether or not it's focal versus diffuse. And there's a number of metrics such as PPG, which is led by Carlos and his team in ALST. It really quantifying whether a lesion's focal or diffuse, because we know focal lesions do really well with revascularization in the cath lab, where diffuse disease ends up leaving a patient with diffuse disease. And even if you put in long stents, multiple stents, they typically have residual ischemia and symptoms. So how we do it really comes down to the pullback. And that's where I think also Philips, again, has taken the lead and has currently the best software available to integrate the assessment of the physiology, so that we're not just looking at that absolute value, but with their Sync Vision co-registration, what they actually do is map out where there's pressure loss and where there's ischemia. So you see with a yellow dot, it gets mapped onto the angiogram, and that does something very important. Not only does it tell you that the patient has ischemia, has a role for PCI, but it actually guides your procedure. So now it's doing with physiology what imaging has always been, a guidance for your procedure, how to best optimize and give the patient the best results. And the key is we're no longer just using this as a gatekeeper for when someone should get a stent. We're using this intra-procedurally to determine, did we do a great job at checking our work, and is further optimization available before the patient leaves the cath lab? And that's being right now evaluated in a randomized controlled trial called Define GPS. Your lab, led by Kareem, has been the highest enroller in the U.S., and that I think is going to inform the world basically on the value of this. But it's modern physiology where we're using the physiology to guide the best way to treat the patient and to ensure that they've gotten the best result. And again, this is a hallmark of low contrast PCI, but it's something that I strongly advocate for people not just to practice in other cases, but this really should be used as standard of care And it's not used in isolation. It's not in imaging or physiology. I remember, when I was a fellow in getting into this field, it was always these debates at conferences of imaging or physiology. Should I IVUS or do FFR? And, fortunately, as a field, both the imagers and the physiologists have kind of merged now, and it's a contemporary PCI operator, essentially, where we realize these are synergistic tools. It's not a one or the other, and you use them together to truly understand the full assessment of a patient so that we could offer them the best results.
And the technology is actually improving. Correct me if I'm wrong, early on when we used to do co-registration with IFR, we had to, you take your first shot, you put your IFR wire, you get your numbers, then you do a pullback, a very slow pullback, and then you have to take another picture to and then the system will recalculate it. But now you can use the same one picture you took from the beginning and you co-register on it. And then you can decide every dot is a 0.1 of your IFR. And then you decide, if you have a diffuse disease versus you have a spot where it's like 10 points, then you need to make sure that's covered. And then, so you think that's the companies and the industry are listening and they're working with us to improve it? Because what we used to do now is getting much, much lower contrast, because I think there's a need and there's people leading the way like yourself and others who's telling industry that, yes, you have the technology, but we still need it better.
Yeah, no, absolutely. The companies, I think, have understood this mission. Philips continues to iterate and help with advancements. The other thing is other companies realize that competitive advantage Philips had. CathWorks is a great example of another solution. So they offer angio-based physiology where before we even wire, without the wires, you can get an assessment. It does something very similar where you can plan your procedure. You see where there's pressure loss, and both with the Philips system and with these angio-based solutions, you can do virtual PCI planning. So you can test out, does a 28 millimeter stent relieve this ischemia, or is there residual ischemia? Should I be going with a 34 millimeter or 38 millimeter stent up front? So you can test this not on the patient, but on the angiogram. And you can test these strategies to figure out what's the optimal result. So I don't go in and put in one stent and then another stent distal edge and then another for the proximal edge. Sometimes you need to cover the edges, but if we can get away from that and have procedural planning like we do with TAVR, we're going to offer better results and a more efficient, higher quality procedure for our patients.
I think cathwork is a whole conversation by itself. I think the importance of cathwork that I see, and correct me, maybe I'm wrong, is not only for like someone like yourself who's very like an advocate for imaging and physiology, but for other physicians who do the angiogram. They took the 6 pictures, the all corners pictures, and then they resist doing an IFR because they do not want to hypernize the patient. They do not want to put a guide. They do not want to put a wire because of the risk. Do you think this is where cathwork will really benefit our patients, is in physicians who can easily just say, just load it to the system, give me a number, and that number give me either, well, this looks fine, it's above it's FFR, so it's above 0.80, or this is below, maybe I need to do something. Maybe what my eyes is telling me is not accurate. Do you think it's going to help both type of operators, or is mainly people who do not do invasive testing?
Yeah, I think it helps everyone. So angio-derived physiology, I think, is going to really transform diagnostic procedures. Our goal in contemporary and modern PCI is to get objective information as opposed to just subjective visual assessment. It looks like a 90% lesion, looks like a 40%, because we both know, if we both looked at the same angiogram, one of us may say 40, one may say 90, and the reality is sometimes if I look at it 10 minutes later, I may say 40 and I may say 90, just the way you're looking at the same angiogram. So I like objective information. It's much better for patients, and angio-derived physiology is going to help us tremendously. It's a game changer for diagnostic-only physicians, but it's also for interventional cardiologists because, again, it's not just a cutoff value. It gives us procedural planning, and we can use it post-procedural or intra-procedurally. So angio-derived physiology, I strongly believe, is part of the future of the modern cath lab. CathWorks, one limitation in the current version is you need multiple views. So for most procedures, that's great. in this subset of the advanced kidney disease, if you're treating a right coronary artery, for instance, you're not going to want to take 3 views to get that value. So that's where we go to invasive. But for patients with minimally impaired renal function or normal kidney function, that's great. There are some of the alternative angio-derived physiology metrics use 2 views. And then there's some stuff coming down the pipeline of single view angio-derived physiology, like from SpectraWave with their X1 FFR. So I think there's innovation and technology coming very soon, which will help to integrate, and different tools can be used for different patient subsets. But yeah, absolutely. The more objective information we can have to guide our procedures, or even for the diagnostic cardiologist, just to determine, do they need a staged procedure or do they need bypass? Very often, it looks angiographically, you have 1 or 2 severe lesions, the other vessel's intermediate. But when we start doing physiologic assessment, we realize that this isn't a triple vessel disease that needs CABG, and it changes their whole revascularization strategy based on comprehensive assessment.
One of the factors that people may push back against doing invasive testing all the time is time consuming for those co-registration. And I think in every lab, when you have a champion, and I think this is important to have a physician who's a champion for imaging and physiology in that lab. We have Dr. Lazizi in our lab who really transformed our lab performance. I think our IVUS numbers and IFR number has been skyrocketed because his advocacy, and the same thing in your lab and other labs as well. But the one downside for operators saying, well, it's going to take me forever. I'm going to have to go back and measure it and figure out this correctly. Can you comment about, one, the importance of having champions from the staff as well who can do those measurements, and what's the role that industry can play to educate them, teach them? Are there courses for them to learn, or that's going to be the physician champion role?
Yeah, so I'm glad you set me up for that, because it's one of the biggest myths is that doing a comprehensive assessment adds more time, and it does the first time you do it. But if you change the way you practice, if you look at the advocates for imaging, these are some of the busiest operators in the country, and what they'll all say is the imaging allows them to be so efficient. The best data for this comes from DisruptCAD3. It was the study that led to the approval of shockwave intravascular lithotripsy in the coronaries. And they had their overall cohort, and they had a pre-specified OCT subgroup. And in the OCT subgroup, operators had to do a minimum of 3 OCT pullbacks, and as many as 8 were performed in the study. And when you look at the OCT subgroup, you would think complex calcified disease, you have to do 3 OCT pullbacks. I can't imagine how much more time this takes than the regular cohort. Not only was there no significant difference in time between the 2 groups, patients in the OCT subgroup actually saved 2 minutes in their procedure. So 3 OCT pullback minimum, and they saved 2 minutes because the operator knew exactly what they're dealing with. They know the next step. And this has been replicated in other studies, such as Calypso, another randomized controlled trial, which evaluated imaging in calcified coronary disease. And the imaging guides you. So your first OCT or IVUS or IFR pullback is going to take time to make sure you're getting it right and to figure out how to interpret the information and apply it. But once you're practicing, you become more efficient, and it speeds up your procedure. So that's the first thing with time. Second thing is what you mentioned is cathing is not an individual sport. It's a team-based approach. And the better your team members are and more comprehensive it is, the better job you can do for your patients. So absolutely, the most successful thing at implementing imaging and physiology is engaging a champion in the cath lab. And you can often find someone who's interested in this, wants to learn more, wants to get more involved, and you make them the super user, and this spreads, it becomes contagious in the cath lab. And it always starts with one champion, and then there's the peer pressure, because people start realizing that their practice is very different than the other operators. And all of a sudden, the nurses and techs who scrub with both types of physicians start putting pressure on, that looks a little hazy. Why don't you image that? Or, I don't know, it doesn't really look that severe. Why don't you do physiology for that? And they start challenging the physician, and over time, this changes practice. And that's what we're seeing. The growth in imaging is unprecedented over the past few years. Just this week, the state of Michigan published their statewide intracoronary imaging update, where intracoronary imaging is used statewide in all-comer PCI 44% of the time. It's the highest reported intracoronary imaging use to date. So this is amazing. We're making change. This is the efforts of all those passionate in this have been trying really for years and for decades to try to change the field. And it's happening, fortunately. So there is recognition of that. And a big part of how this is happening, aside from just the data, are these educational efforts. The past 5 years, there's been a tremendous effort from industry and from private groups such as the Dallas PCI group, our group with Optimizing PCI, and many other groups around the world who've really dedicated and focused on educational initiatives, whether it be virtual or in-person hands-on training courses or these complex PCI conferences, which allow people to get the skills and exposure to these techniques and then implement it into their practice. And also just in the ease of use. As technology is advanced, it's becoming easier and easier to use and to master. We started this, you mentioned I did an intracoronary imaging fellowship. And when I did this almost a decade ago, it took a year to figure out what you're looking at with the IVUS and physiology tools that we had back then. Nowadays, so much of intracoronary imaging is automated with artificial intelligence that you could spend 15 seconds with looking at an OCT or an IVUS, and it tells you what lane stent, where the minimum lumen area is, what it is, where you need to treat, and what type of plaque you're dealing with, whether it's lipid or it's calcium. All this gets automated now with automated vessel measurements, and that's the future. So you don't need a 1-year fellowship to be able to implement imaging in your practice. You need to go to a 1-day course, and I'm confident that you attend the 1-day course with the current tools. You get the foundation you have that you could then practice this and implement this into your practice and change the way you practice.
I think, as you mentioned, in growth in endovascular imaging, especially in academic centers, we're seeing more and more of our newly graduate over the last 5 years who are heavy users of imaging and physiology, which extremely refreshing, let's put it this way. And we, even in our lab, we'll see some of our fellows telling us like, hey, you didn't image this case, you should do imaging. And I think that's the way the movement can change. I want to finish up with the last 5 minutes. I know I took way longer than we expected. It's always a pleasure to talk to you, but you mentioned briefly OPCI, Optimization PCI course. I know you're the co-director for this, so you guys have been doing phenomenal work. It's a very unique conference. It's different than many other conferences. Give us just a short sentence of what is OPCI? What's the idea behind it?
So, OPCI, Optimizing PCI, it started a little over a decade ago as a really focused meeting. We saw there was a gap in education and focus on intracoronary imaging and physiology. So it began as an annual meeting just over a decade ago in New York, where the whole focus was dedicated on intracoronary imaging and physiology. COVID changed the world, and at that point, it stopped their in-person annual conference, which had been growing at the time, and forced us to go virtual. And what we changed to, we started doing just weekly meetings where we would have our physicians here at St. Francis just do a journal club and cover some of the latest literature and do live cases once a week where we broadcast it and be able to focus on different techniques and technologies. And that has continued now in the post-COVID state, and all that lives on our website at opci.live. But what we realized was imaging and physiology now wasn't just this niche tool and this abstract thing just for imagers and physiologists, but this was a part of modern PCI. And it's evolved where we do hands-on workshops and training programs and regional courses where the whole focus is on exactly what it says, optimizing percutaneous cardiac procedures. And how do we get better results for our patients? And whether that is imaging or it's lesion preparation with calcium modification tools or different access techniques or mechanical support, whatever it is, how do we get better results for our patients? And so the focus has gone way beyond just intracoronary imaging. We've expanded to structural and cardio-oncology and way beyond our initial foundation, but the purpose stays unchanged. How do we improve outcomes? And we try to keep it innovative. And with the education, the more we can engage not just physicians, but cath lab staff, nurses, techs, fellows, I think we're furthering the mission of improving outcomes. And I think it's an important one, but it's very rewarding to see the growth in adoption of some of these best practices like intracoronary imaging. And, it's certainly something that we don't do alone. There's been a number of groups like yours and a few others around the world who are helping to educate basically anyone who's willing to learn. And it's changing their practice. And it's what's great is also we learn from each other. A lot of people from your group have come over to New York. Our group always comes to Dallas each year for your conference, and just the shared exchange of ideas is what's furthered the field. So like with ultra low contrast PCI, this began several decades ago. Columbia, Paul Tierstein, Jeff Moses, I think, created this for one of their family members was undergoing an angiogram, and that's where they got this concept to try this. And then, through the years that shared information and exchange of ideas, Javier Escanad then pioneered a number of different ways to further this. And then, one of my colleagues, Ziad Ali, helped package everything together and really innovate this. And it's the shared ideas that allowed us to get better, innovate, and keep coming up with better solutions for our patients. And that's partially why these conferences are so important, which is really just this exchange of ideas, because we all observe things in a little different way. And if we work collaboratively, we can easily come up with better approaches. And it's not just physicians talking to each other. The key is that we connect and have this collaborative conversation with industry and society so that we can all work together towards that same mission on how to offer better care.
Dr. Shlofmitz, thank you so much for your input today. Very informative. Any last comment for the audience?
Well, no, thanks so much for joining. And the best thing, if you're looking to implement this into your practice, is come to a local course. There's so many resources available online to take part in this, and don't be afraid to work with industry. Talk to industry, and tell them you're trying to get involved in this, and they can set you up with the right resources. Send you to a proctorship course, bring in a proctor there, have industry representatives actually help support the case and help you implement a lot of these tools as well. So thank you so much for this invitation. It was great talking with you today, and I look forward to seeing you next in Dallas.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
on Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hady Lichaa
and Sami Seifo.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.